Hello, I'm glad you're here for our webinar. This is a talk on attachment-based family therapy. My name's Guy Diamond, one of the developers of the work, and I'm here with Suzanne Levy, my co-developer and training director for our attachment-based family therapy training center. We're going to give just a brief talk today. I know everybody's busy out there, but we wanted to give you a little bit of overview of the theory of our work, and then Suzanne will give you a little bit of flavor of the clinical work. There should be an email address if people are interested in our work at the end. You'd like to learn more, you can contact us. Today, if you want to ask questions, we won't have enough time to respond to them in this live format, but if you send in questions in the question box down below, we will certainly write back a thoughtful response in the next couple days and send it out to everybody online. So with that said, we're going to start the talk and hope you find this of interest. Attachment-based family therapy is developed, as I said, by myself, Suzanne, and Gary Diamond, who works in Israel. We've been doing this work for about 15 years. There is extensive research now that supports the effectiveness of the work, and we are listed on SAMHSA's National Registry of Evidence-Based Practice. Let me talk a little bit about the theory base of the work. Our work is founded in attachment theory. The slides are not going. And we are, instead of using sort of general systems approach, we are using an approach that's based in attachment theory, and here's how we think about this. When children experience parents as available and responsive and attuned to their emotional needs, children begin to feel that parents will love and protect them and that they are worthy of love and protection. And this is the essential nurturing environment that children need for healthy development as a young child. Over time, children begin to expect this of parents, and they sort of internalize a working model or schema of what I can expect from relationships. So if I've been treated well as a child and learned what that's like to be in a loving, nurturing relationship, I begin to feel like that's what I deserve and that's what I'm capable of, and I go looking in my adult life for relationships that would provide me the same kinds of love and affection. If I've been treated poorly, that's what I become familiar with, and I unfortunately will go and look for relationships that reinforce those kinds of experiences as well. And unfortunately, we see this in our clinical work all the time. Children who've been abused in their childhood and then become more, go look for relationships that continue to perpetuate that abuse. But attachment theory also has an interesting framework on emotion regulation, which is increasingly becoming an important area of thinking around intervention work, certainly for adolescents and a number of disorders. So the attachment system is actually activated when a child feels threatened or worried. Kid falls off their bike, scrapes their knee, they feel scared, they feel uncomfortable, attachment gets activated, they turn and look for their parents to provide protection and comfort. And when the parent is available and sensitive to that need, children's fears are calmed. And over time, this is how children learn how to self-soothe themselves, and they begin to internalize the capacity for down-regulating worrisome emotions. And this is sort of Bowlby's theory of emotion regulation and how people come to gain these skills. When this environment's not available, children don't have the normative developmental context to help them develop those skills. That's how Bowlby thinks about it. And when it's not available, this is what Bowlby talks about as an insecure attachment. Kids develop a low expectation of parental availability and support and protection. And essentially, children develop a sort of defensive style against being hurt. Some kids develop an avoidant or dismissive approach. They deny the need for love or comfort. I couldn't get it from my parents, therefore I'm going to feel like I don't want it anymore, and I'm going to suppress or deny the feeling in me, the desire in me to be loved and protected. We see a lot of these kids in clinical practice. Another approach is a more sort of anxious, preoccupied style. We see this a lot, kids who are excessively concerned with closeness, yet constantly fearing abandonment, and there's sort of a push-pull chaos in how they reach out for love and attention from their parents. A third category is considered a disorganized category, where kids really develop no clear, cohesive strategy for regulating their emotions and their attachment needs. These are often kids who have experienced severe trauma, where the parent themselves is the source of fear and threat. And unfortunately, we see this in a lot of abuse cases, or marital conflict and other kinds of family environments, so that it's really unsafe for kids, and they tend to develop this more disorganized style, which tends to be associated with the most disturbed kids. There's a lot of ways that the attachment environment can be ruptured or damaged. Certainly there are life events that we call big T traumas: neglect, abandonment, physical abuse, sexual abuse, illness. These are things we see in our practice all the time. I'm sure you do. These things are clear traumatic events that can create a lot of insecurity and a very unsafe environment for kids to be able to turn to parents for love and protection. Sometimes it's not so a big T, but there can be what we call little t traumas. This can be caused by parental stress, issues of poverty, psychopathology, marital distress, racial discrimination, sexual discrimination. These things put stress on a parent and make them less available to be there for their child in their time of need. There's also, this can lead to very negative family environments: high parental criticism, low cohesion, high control, low warmth. These are the sort of fabric of family life that can contribute to secure attachment, or if it's too much of this as a negative style, can certainly promote an environment where kids don't expect to be taken care of, don't expect to be loved and protected, and instead develop defensive strategies against those disappointments. Certainly there's issues of temperament, psychopathology, medical illness from the child that might contribute to that stressful environment. We know that. But I think everybody in the field believes that even from a temperament point of view, the way the environment, the family and parenting environment responds to a child's temperament has a lot to do with how that temperament will evolve and what kind of skills the kid will develop. What we also know is that attachment is not only relevant during childhood, early childhood, and that extensive years of research have shown that attachment in adolescence is as important a fixture of psychological development. The old concept of storm and stress, that the normative developmental task of adolescence is separation and individuation, has been completely debunked by years of developmental research. That in fact what we now know, that the central task of adolescence is that to develop autonomy while maintaining a backdrop of attachment. And it's more about negotiating, how do I stay connected and yet become my own person? Clearly a moderate degree of conflict is normative. Kids fight all kinds of events. I want to stay out later, I want to take care, I want to leave my room a mess. And these actually can become healthy opportunities for kids to assert themselves, for parents to help kids learn how to negotiate, kids to articulate their needs. These are normative, healthy developmental challenges. But when conflict becomes so severe that people hate each other, people feel rejected, people feel extreme levels of hostility that actually damages the developmental attachment fabric, that's when conflict is not a healthy context, and that's what we too often see in our clinical work. This is a quick snapshot of how we then view the development of depression in work with adolescents. There's certainly other factors, biological, temperament, as I've said, but these are the targets. These are the things that we think about in attachment-based family therapy that contribute to depression, and the things that we target in our intervention model. So for the adolescent, we're thinking about emotion regulation. Most of our depressed suicidal kids are what we call suppressors. They feel strong feelings, and instead of expressing them, putting into words, they suppress that feeling, they withdraw, they retreat, and many of our kids, they actually cut. A lot of our kids have a very difficult time with managing attachment and autonomy. Either they themselves can't negotiate it well, or their parents have not been available in a way that allows them, teaches them how to negotiate. And a lot of our depressed kids have grown up in a chronic dysfunctional environment and tend to have more insecure attachment styles, dismissive, preoccupied, disorganized, as I've said before. From the parent side, we often are thinking about sort of intergenerational patterns. What was attachment like for these parents when they were a kid? What did they get? Did they grow up in safe, secure environments where they could go and seek comfort and help? Or were they also had to defend against the hurt of abandonment, neglect, avoidance, suppression of emotions? And unfortunately, when we're working with more dysfunctional families, our parents that we work with typically have a history of attachment ruptures themselves, which get in the way of their capacity to parent. We also work with a lot of parents who are struggling with depression, substance use, even personality disorders, and those also make it difficult for them to kind of come out of themselves and be available to their kids' emotional needs. And we see a lot of current stressors. We tend to work in our studies with a lot of kids who come from low-income families, so there's issues of poverty, there's issues of racism, other sort of environmental, economic stressors that make it difficult for parents to be the kind of parent that they themselves want to be. So this is a kind of picture. When these sort of factors collide together, what we see is kids who experience attachment ruptures and generally an insensitive caregiving environment. Not that parents want to be that way, but sometimes these sort of factors just get in the way and make it difficult for them to come across and be who they want. What we want to make sure you know, and hopefully you'll see a little bit, and certainly if you follow our work, is this is not a blame the family model. It's not that parents are incompetent and that's why kids are in trouble. What it is, it's a strengthen the family model. We know that if we can help parents recover some of the normative, instinctual caregiving skills that we believe are in there, buried under some of these struggles, that they can become, in fact, the medicine for these kids, and they can be the curative agent. And that's how we approach parents. Build them up, remind them of how important they are, help them resuscitate who they are and their competent skills, and help kids revive some sense of hope that maybe their parents could be available for them again. And that's the reparative work that we're going to see a little bit more. I'm going to turn the talk over to Suzanne. She'll give you a little sense of how what I've said already is really our sort of our dysfunction model. How do things fall apart? What do we have to focus on? Suzanne's going to talk a little bit more about the actual strategy of the work and how we accomplish some of these goals. So turn it over.
So I'll be discussing the clinical model. So generally, ABFT is done in 16 to 20 sessions. It is designed to be a brief therapy. In the age of managed healthcare, we know that mostly managed healthcare wants brief therapies. However, we do have many therapists out in various agencies doing this for longer than 16 to 20 sessions. It is an empirically informed and supported treatment. So what you're going to see here today is the different components are informed by research, and we've also studied it in research and know that it's effective with adolescents who have depression, suicide, and suicidal youth with sexual abuse. In addition, we provide the principles and treatment strategies, but ABFT allows for flexibility and creative adaptation. So we know that every family is different, and every family is going to come in with their own issues and the ways that they interact with each other and with you. And ABFT, while it provides the structure for how you do the therapy, we know it's important that the therapist themselves is present and brings their skills and is being creative and mindful when doing the therapy to make sure they're adapting the therapy as appropriate for the family in which they're seeing. The therapy is organized by 5 treatment tasks. The tasks represent the core challenges and processes that build on each other and lead to change. So these tasks do have an order to them, and within each task there are phases, and these phases within the tasks lead to the primary change within each task and build upon one another. The tasks do help organize treatment planning and the goals of each session. So when a therapist goes into a session in ABFT, they have a goal in mind. What are they trying to achieve for each session? which helps the therapist be intentional. So that during the session, the therapist is constantly monitoring, am I achieving my goal? Do I need to switch strategies in order to achieve my goal? And what we find is by structuring therapy around these tasks that we get to core conflicts quickly, that this therapy is fast-paced and we get to the core issues quicker than when you're just doing therapy in general. So the first task of ABFT is called the Relational Reframe task and is typically done in the first session after your assessment is completed. The goal of the Relational Reframe task is to really shift from the adolescent as the problem to the family relationships as the solution. We know that many families come to therapy bringing their adolescent and they ask the therapist to fix their child. And that is, we're going to help the family fix their child, but it's not going to be just the therapist meeting alone with the adolescent. That what we do in that first session is really help the family talk about family relationships. And so we want to highlight what has gone on in this family that this adolescent is no longer turning to their parent for support. Or if their adolescent is turning to their parent for support, how come it's not enough to give them relief? And so we're going to highlight the relational rupture and really focus on the relational rupture for a good portion of that first session. We want to understand what is getting in the way. We want to get into how is the fact that there is this rupture affecting every member of the family. We want to increase the longing for the members of the family to want to reconnect and be there for one another. And really what we're doing is putting the responsibility for change on all family members. By the end of that first session, the goal is to really have the family agree to what we're going to be working on in treatment. So we want to establish a treatment contract. So the question is, can we work on the relationship first? That we really believe that if we can work on the relationship and make the relationship have a more secure attachment, that parents can serve as that family safety net and be there to help the child when they're having a rise in their depression or thoughts about suicide. So by the end of that first session, we want the family agreeing to work on that relationship. Then we want to meet alone with the adolescent. So we split off into task 2. And this is where we're going to be building alliance with the adolescent. Task 2 is typically 2 to 4 sessions. And so in this session, we want to really, our main focus of task 2 is to help the adolescent develop a more honest attachment rupture narrative. So we want to help this adolescent understand how have they gotten to where they are in their relationship with their parent, and how is that affecting them out in the world? How is it affecting how they view themselves? And how is it affecting how they interact in other relationships? And so how we do this is we want to identify breaches of parental trust. So what are times in which the parent has let the adolescent down? Or what are the things that go wrong in the relationship? Or when the adolescent is feeling suicidal or depressed, how come they aren't reaching out to their parent for help or support in those moments? So we identify these breaches of parental trust. And then we want to get some examples of that. And that's going to help us really access more vulnerable emotions around these breaches of parental trust. So we want to get in and explore, how do these breaches make the adolescent feel? So we want to get at both the vulnerable emotions and assertive anger associated with these ruptures. So we know that adolescents often have multiple feelings. So we're going to explore all of the emotions that are there around these breaches of trust. And we're going to bring in attachment themes and try to understand kind of what are the core root of these issues. So attachment themes might be things like feeling uncared for or unloved, or feeling abandoned or betrayed by one's parents. Once we understand all of those pieces, we want to help the adolescent understand, how is this affecting them? What does it mean to them that these things have happened? How is it affecting their relationships? And then we want to link it back to their depression or suicide so that they understand how their attachment ruptures are related to their sad feelings or thoughts about wanting to kill themselves. And then finally, we want to help the adolescent amplify their entitlement and their skills to express these disappointments directly to the parents in a regulated way. So we find that often some adolescents have expressed how they feel to their parents, but it's been done in a really dysregulated way, which only leads to further conflict in the family. Or adolescents feel as though they don't have the right, or it's too scary to bring these things to their parents. and therefore they haven't brought them to their parents. So the task of task 2, after helping the adolescent understand their attachment narrative better, is to prepare the adolescent for the attachment task. So we, in that moment, are going to help the adolescent really think through what is it that they want to say to their parents? What are their fears about bringing these issues to their parents? And we're going to help them talk through their fears, problem solve around that, and we're going to give them the skills to be able to come to a conversation with their parents and discuss these issues that they've been upset about and really feel heard and do it in a regulated manner. So just to get a little bit more specific of what do we mean by attachment ruptures, this relates back to what Guy had spoken about earlier related to the risk factors for insecure attachment. So we find that sometimes ruptures are traumatic events. For instance, we have adolescents who will come in and say that their parent didn't protect them when another parent was abusing them. So how can I trust this parent now? Another example of a rupture would be negative family interactions. So for instance, I don't feel like my dad accepts me, or my mom is critical and controlling, or when I try to talk to my parent, I feel like they're criticizing me or don't understand me. Another example of ruptures might be parents' own psychopathology. So, for instance, we know a lot of kids who are depressed have parents who are depressed or experience anxiety disorders. So we've had kids tell us, you know, my mom freaks out or gets really anxious when I tell her my problems. I don't want to burden my mom with my problems. They have enough on their plate. So these are just some various examples of attachment ruptures. And like I said, once we get these examples, we're going to help the adolescents really elaborate on their attachment narrative. So how do these different ruptures affect them? And how has it led them to how they interact in their relationships currently? And how does it affect their depression and suicide as well? So we're doing task 2 with the adolescent. And at the same time, we're often doing task 3, where we meet with the parent alone. So we might meet with both the adolescent and the parent each for an hour in a week, or we might meet with the adolescent for 1 week and the parent with the following week. Or you might decide, if the adolescent is very high risk, that you'll split the sessions, and maybe you do 25 minutes or half an hour with the adolescent and 25 minutes or half an hour with the parent. But task 3 is also you're meeting with the parents alone. And in 2-parent families, sometimes we're going to meet with the parents together, and sometimes we meet with them alone. It really depends on their clinical presentation. Oftentimes we'll try to meet with both parents together at first, if parents are currently in a relationship, and do a little assessment of their marriage and see if we can continue the work with both of them together, or if we need to split them up to do some of the work. Again, the Alliance sessions with the parent are about 2 to 4 sessions, just like the Adolescent Alliance sessions. And really what we're trying to do in the context of these parent Alliance sessions is, first we want to join with the parent, and we also want to understand their psychological, historical, and social forces that impact their parenting. We know parents have a lot of stress going on in their life, and that stressors that are existing in a parent's life can really influence their parenting, and those stressors can directly affect their adolescence. And so that's going to further impact their parenting and their relationship with their adolescents. We also know that parents are coming in to their parenting role with their own attachment history, and that's going to influence how they are as parents. That often if parents didn't have good models of parenting when they were younger, it's going to be much harder for them to do the things that are associated with secure parenting for their own adolescence. So we really want to get in and understand their own history and their current stressors. We listen to parents' stories. We validate their stories. We really try to get parents to understand that we're caring about them and that we're going to take care of them just like we're taking care of their adolescent. And that we find that when parents feel like you really heard them, that they then can take a good look at their own stressors and their own attachment history and have a really honest look of how those things have influenced their parenting and how those things have influenced their adolescent. And we find that when parents can do that, it starts helping them build empathy for themselves as well as building empathy for their adolescents. Once parents have a better idea of how their own parenting and their stressors, or their own history and their stressors have influenced their parenting, we then try to activate the parent's own caregiving instinct. That we find that parents now want to do something different, that they realize their stressors are impacting how they parent, that they realize their own history is impacting them, and they really want to do better and make changes. And so the next phase of task 3 is to prepare the parents for the attachment task. That we know parents are coming into a situation that may be without all the skills that we want them to have. And so just like we did with the adolescent, we're going to help prepare them for this conversation. So we're going to help them understand what is it that it's going to happen in task 4. What is it that's going to happen in the conversations when they come together with their adolescent? What are their concerns and fears about having this conversation? And in addition, we're going to give them emotion coaching skills. So we teach them skills that they can use so that when they get into task 4, they can be present for their adolescent and validate them and make their adolescent feel heard. And we're also going to ask parents if we can be there to help them. That we know we're asking parents to do something very different than many of them have done before. And so we're going to serve as the coach for the parent in that next task. So at this point, we have the adolescent ready and we have the parent ready. So it's time to bring them back together. So task 4 is called the attachment task. Task 4 can last from 1 to 4 sessions. And the goal of task 4 is to really organize a corrective attachment experience for both the adolescent and the parent. So we're going to bring the adolescent and the parents back together to have conversations about the core attachment ruptures. Initially, the adolescent is going to talk and the parent is going to listen. And we're going to help the parent listen and explore what the adolescent is feeling. The adolescent is hopefully going to feel free to talk, to discuss the difficult and vulnerable issues, and the parents will be receptive and available. So the core mechanism here that we're using is enactment. So in task 4, we want the parents and the adolescents talking to one another as much as possible, and the therapist stays out of it. The therapist jumps in to coach when necessary, but gets out when they can so the conversation can be between the parent and the adolescent. We find that that's much more potent than the conversation coming through us. So when this happens, when the conversation can be between the parent and the adolescent, we find that this often helps to resolve conflicts. For the first time, adolescents feel heard. They feel like they have a voice. They feel like their parent is caring about what they have to say, and they're seeing that their parent is sensitive and available. And that helps build confidence and can hopefully build new expectations that in the future, their parent can be sensitive and available to them. The adolescent is going to practice these new conflict resolution and emotion regulation skills that they've worked on in task 2 with the therapist. And the parents are going to use these emotion-focused parenting skills that we've taught them in task 3. So all of this leads to the corrective attachment conversation. So here, the adolescent is coming into task 4 with increased emotional awareness, tolerance for difficult emotions, and more cognitive appraisal. So they're worked on that in task 2, and then they're coming in to discuss this in task 4. And then we find through having these conversations, it further increases emotional awareness and cognitive appraisal. We find that it also leads to increased capacity for interpersonal conflict and resolution. So having adolescents practice having these hard conversations and having parents respond in a sensitive way is going to make adolescents feel more comfortable to have conflict and raise hard things with the parents in the future. And we find that this helps adolescents develop more coherent narratives of their attachment ruptures. So actually discussing these things with the parents allows parents to bring in new information and helps adolescents have a more cohesive understanding of their own attachment narrative. And this leads to sustained engagement on the adolescent's part. On the parent's part, they're coming in to task 4 and they're validating the adolescent's perceived injustices. They're facilitating the emotional expression and understanding from adolescents. And they're also providing new information and disclosure of personal vulnerability. So in task 4, after the adolescent fully feels heard, then the parent is allowed to tell their side and bring in new information. Oftentimes we find out there are a lot of things that were going on for the parent that the adolescent never knew about or understood. And with that new information, it helps the adolescent understand why the parent has done what they've done. And we find that with doing this, that the adolescent sees the parent as being a more sensitive caregiver. So we stay in task 4 as much as we need to discuss all of the core attachment ruptures. Once we've done that, we move on to task 5. which is the autonomy promoting task. So here we're really trying to promote autonomy and competency in the adolescent. And really what we're working towards is revitalizing a goal-corrected partnership, that when adolescents are securely attached to their parents, that they can work with their parents to achieve new goals, to really promote autonomy while staying attached. And so we find that cooperation emerges from the desire to maintain connection. So when we're in task 5, there's new content. We find that now parents are able to help their adolescents talk about other stressors besides the attachment ruptures. So this is a time where adolescents can start talking about all of the other things that contribute to the depression and suicide. We know that families are not the cause of adolescents' depression and suicide in many cases. In some families they are, but often for other adolescents, the cause of depression and suicide is other things like bullying or failing academically or peer problems or romantic problems, and that not being able to go to the parents has been adding to that stress. So now in task 5, we're bringing in all of those other reasons that the adolescent feels depressed or suicidal, and allowing the parents to be a source of support for the adolescent, to be that secure base that they haven't been able to be in the past. We also, in task 5, are going to help build adolescent competencies, because we know that when an adolescent is doing things that they enjoy and feel good about, that helps build self-esteem, and that's going to further buffer against stress. And so we're going to help make sure that they're succeeding academically, that they're getting out there and being social. We know that adolescents, when they're depressed, they withdraw from their social climate, they stop doing things that they enjoy. And so we want to help parents, help the adolescents re-engage in their social world, re-engage in their hobbies. We also, in task 5, will talk about issues of identity development. So for many adolescents, these are really relevant topics, and we want parents helping adolescents think about who do they want to be in their romantic relationships? How do they want to act? How do they want to be treated? We want to help parents talk with their adolescents about sexuality. When is it time to have sex? What are the family values around sex? What are the adolescents' values around sex? And how do they maintain having a healthy sexual life if they are going to engage in sexual activity? It's also a time where we help families talk about ethnicity and race, and we want them to focus on ethnic pride and racial pride, as well as perhaps areas of discrimination. And we'll also help families talk about religion and spirituality and class in stage 5, in task 5. Task 5 you can stay in as long as you need to. So we find that task 5 looks like more general family therapy that's out there, and that we find that when you know you're done with task 5 is when families are coming in, you as the therapist start them out on a topic, and they just talk and you need to do nothing. When families are able to talk about these hard topics on their own, and you're no longer needed, we find that that's time to terminate therapy. So that's a brief overview of ABFT. While we aren't right now answering questions that are being sent in, some common questions we get when talking about ABFT is, can adolescents be on medication when engaging in this therapy? We support adolescents on medication. Many of the adolescents that we treat when they come in to see us are already on medication. We believe that if an adolescent is on medication, it's really important as a therapist to reach out to their treating psychiatrist or whoever is prescribing that medication so that we are on the same page with the prescribing psychiatrist or physician, and that we can be giving them feedback because we're seeing the adolescent much more than they are. Sometimes too, if we see that an adolescent is coming in for treatment and they're either on medication or not on medication, but they're starting to not do so well, that we will hook them up with a psychiatrist so that we can make sure that they do get on medication. Another common question.
Yep. You know, one important thing about medicine, because of the frame of the therapy, that this is a relational focused work, the introduction of medicine can reintroduce the idea that this is just a biological problem and that's, if we give medicine, it's all over. So I think the frame for us about medicine is he's so depressed, he's so withdrawn that it's making it difficult for him to engage in the therapeutic kind of conversation. So this is really a resource to augment what we're doing from a relational point of view. I think another thing we always struggle with is, you know, how to, the management of the medication becomes an autonomy issue. who's going to monitor it, who's going to manage it, is the kid going to do it on their own? And again, it becomes another opportunity for the family to discuss and sort through what's the way that this family is going to handle something like this in a more clear and negotiated way. So it's really an opportunity for therapeutic development rather than a side track from it. So I just wanted to add that.
Another common question we get is, what if the parent themselves has mental health issues? Most of the families, or many of the families we work with, the parents themselves have mental health issues. We've worked with parents who have personality disorders, depression, anxiety, substance abuse disorders. What we find is, those parents can be harder to work with, but we still find value in doing the work. We will meet with parents and we're going to assess where they're at and are they capable of this work. We request that if parents are substance using, that they come to sessions sober so that we can do the work. Now, we find that most parents who have their own mental health issues are able to do this work despite themselves not being in the best place mental health-wise. That often parents can do for their kids what they can't do for themselves. We will work with parents to make sure that they are taking care of themselves. We'll refer out for individual therapy for parents as well. The caveat to this is if a parent really is too fragile to do this work, then we will put a hold on joining them back together and doing task 4 while we shore up the parent and make sure that they can get stronger in order to do this work. Is there anything?
Yeah, I like what Susie said. The parents will often do for others that they can't do for themselves, and we often find that they're more motivated to go to therapy for themselves if they think it's going to benefit their child. A lot of parents will say, oh, I don't need treatment, I'm fine, I'm doing fine. But when we help them understand how it's getting in the way of their capacity to be available in ways that they'd like to, it's just one added leverage to try to help them get into services. So it's just another way we sort of think about the relationship as a motivational factor for health in both the kid and the adolescent. It's another piece we often talk about.
Okay. So now I'm going to turn this back over to Guy.
So that really concludes our talk. We do, for those interested in the work, we have a new book out that came out in 2013. It's really the culmination of really 15 years of research and training that we've been doing here in Philadelphia and around the world. If you'd like to pick up the book, you can find it in a number of places. There's also trainings going on. We're doing a training here in Philadelphia in October, in Western Pennsylvania in October as well, and we do a lot of training overseas. So if any of our European colleagues are watching today, you might want to find out about this conference. We are constantly doing trainings twice a year here, and we do travel around America and nationally and do a lot of training and workshops. If you have any interest in bringing us out to do some work, we could be happy to talk to you about that as well. And that's really what our work is about, and we hope you find it interesting. We've been collecting questions in the bar. Suzanne and I will certainly get to those questions and try to address them and send them out to everybody. I hope you found the talk interesting and helpful, and we hear from you soon. We also have a Facebook page if you want to just stay up to date on publications, conferences, and that kind of thing. You can find us on Attachment-Based Family Therapy on Facebook. Thank you very much for coming. I hope you found this interesting today.